Dear colleague, welcome. It's Dr. Jack with today's blog post, and it's called A Landscape of Knowledge. And it's really focused on helping you study more effectively for your board exam. The main goal is to turn passive learning into active learning. And so I want to start off by talking about data, information, and then knowledge. So if you look at the upper left, so each of those blue balls just represents like an isolated, idea or, datum, some piece of information, but it's unconnected. So then when we can look at other data points locally and connect them up and see the relationships there, then that becomes much more meaningful. So data has little meaning, information now has more meaning, but if we can turn it into knowledge, it becomes most meaningful and valuable. So basically, turning information into knowledge is incorporating that new information into our existing landscape of knowledge and thereby expanding it and deepening it. So we are already able to have a context upon which and within which to take new information and incorporate it. We can already make sense out of it because of our existing, extensive knowledge of the world and of that particular knowledge area that we're interested in learning more about. So this is making sense. So isolated data points, they're pretty meaningless by themselves. Information, I'm making sense of the data points locally. Knowledge, I'm really looking at like the big picture, and I'm incorporating the new into the existing knowledge base. So here's an example. Let's say there's some new ADHD research study and the results. So data, it may be the test responses of individual subjects with ADHD, and another datum is test responses of individual subjects without ADHD. And, it's meaningless. Like until I could compare them, right? I need both, I need a comparison group, right? So then if I can, and I run statistical analyses and say there's statistically significant differences between the test responses of the subjects with ADHD versus those without. Now I've turned it into information. The knowledge, okay, so now I've read this study on ADHD, but I already know a lot about ADHD. And I'm like, oh, well, that's very interesting. It somehow furthers my understanding. And I can say like, wow, that really confirms what we already know, or maybe shockingly it doesn't. Maybe it's completely unexpected. And maybe then I'm wondering, well, maybe this is just kind of a poorly designed study. It's meaningless. It was poorly designed or poorly executed. Or maybe there's something new that we can learn about ADHD. So that's just a simple example. So now, what does this have to do with studying for your board exam? Well, I believe that this is very apropos to passive versus active learning. So passive learning, this is, and individuals can spend a lot of time learning like these isolated pieces of information, right? So data points learned, memorized, often repetitively. People spending, I remember in college, in medical school, staying up all night, and they were doing a lot of memorizing. And I do agree that in medicine there's a lot of things to memorize, but it's necessary, but it's not sufficient, right? Now here's the problem when you continue to memorize isolated facts over and over. They become familiar, and so it gives the learner a false sense of understanding them, as if they gain more knowledge, but maybe they haven't. Maybe they just memorized something that still remains isolated from their existing knowledge base. So active learning really entails considering how each new data point that you're learning relates to other data points locally, right? And then also to your existing knowledge base. How does it fit in, right? So you have to consider relationships, the implications between the new information and your broader knowledge that's already well understood by you, right? So the knowledge categories are, we have these objects, these data points, right? The pieces, the datum, each datum, right? These are ideas, some information, isolated facts, right? They're the dots. And then the connections. This is like looking at the relationships between the objects. So objects, you can think about that each object has properties and it has boundaries. And then the connections, you're looking for similarities and differences between other already known and understood concepts and how they relate to the new things that you're learning. So I'm going to demonstrate this with like the simplest example I could think of, which is looking at the diagnostic criteria for major depressive episode. And I chose it on purpose because this is something we all know very well. And I wanted to have something so simple to demonstrate still how more information could be sucked out of something we already know by really engaging in active learning, by looking at the properties and the boundaries and the connections among individual pieces of information. So these are just the major depressive episode criteria that we all know. 5 or more symptoms present nearly every day during the same 2-week period, representing change from previous functioning, where at least one symptom is either depressed mood or loss of interest or pleasure. And then we have all of those symptoms. I believe I listed them according in the same order they are in the DSM-5. So then let's say I'm studying this. Let's say, maybe I'm new at this. I'm studying these criteria. And all of a sudden I start noticing something that, if I reorganize them, all of a sudden they make a lot more sense to me. So I notice like out of these 9 criteria, 3 of them could be considered, related to emotions, either directly emotions like depressed mood, and then others that, may have some cognitive and maybe behavioral components, but also, let's say, have a strong emotional component. Feelings of worthlessness, right? The word there is feelings of worthlessness, and then diminished interest or pleasure. So I have 3 emotionally related symptoms. But then lo and behold, I would just for the first time maybe realize that 5 symptoms are neurovegetative symptoms in major depression: significant weight loss or weight gain or change in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, difficulty concentrating. And then I have another one that's related to cognitive content and to behaviors, thoughts of death, suicidal thoughts, or engaging in suicide-related behaviors, right? So all of a sudden it's like, wow, I feel like I really learned something new. And then I start thinking, wow, that's why, I see patients, I get sent patients from internal medicine where, it's unclear whether the patient has depression or maybe it's just diabetes mellitus or is it comorbid or what's going on, because so many of the symptoms are actually shared between diabetes mellitus and major depressive episode. And then the other thing I notice is, lo and behold, how many of those symptoms do I need? Hold on, 5 or more symptoms. My God, I could get 5 criteria for someone with diabetes mellitus. Oh yes, but I need to have either depressed mood or diminished pleasure. You see, I'm kind of like, again, something completely well known to all of us. I'm really like thinking this through as I'm learning. Okay, so now let's say I'm looking at really the boundaries of these symptoms. So then I say emotional symptoms. Okay, I need either 1 or 2. I either need depressed mood most of the day, nearly every day, or I need diminished interest or pleasure. Wow, I can have a major depressive episode without even experiencing depression. Okay, wow, that's really interesting. So I can have alexithymia. Oh, then really I need number 2. I really need to make sure the patient, I assess the patient for diminished interest or pleasure. How do I do that? I'll ask them what hobbies they normally had and what they did for fun, and are they still doing it? That's like a good entry point into that symptom, right? All right, next one is like, oh, look at this. Most of the day, nearly every day. Okay, all right. So if I'm taking my exam, I really, maybe they're going to trick me. I don't know if they will, but maybe they're going to just make it seem like the depressed mood is more sporadic. Maybe it's just very situational and it's really not every day. Okay, I'm going to keep that in mind, okay? Next thing, depressed mood. By the way, what is depressed mood? Does that mean sadness? Well, it does, but depressed mood is really, it's kind of funny we keep using it, because depressed mood really would more accurately be called dysphoria, because any kind of negative emotion is probably good enough to meet criteria here. In fact, I've met many patients who have more of a sense of dread, of anxiety, of uncertainty, of incredible vulnerability. They're more like, the anxiety, if I had to capture it with one word, they're feeling more anxious than they are sad. But, that probably meets the criteria, right? But I'm wondering, like, how do they come up with that term? All right. So again, this is already something I mentioned, like, wow, these large number, 5 of them actually neurovegetative symptoms. And if I wasn't forced to pick depressed mood or diminished interest or pleasure, I could meet criteria for major depressive episode if I had diabetes mellitus, okay? So you see how I'm kind of thinking all of this through super simple example. Obviously, this would make a lot more sense if we had, we're really struggling with something new, right? Then when before I kind of exit, my review of major depressive episode criteria, it's like, what about bereavement? Since I'm here, let me kind of make sure that I understand the boundary of a major depressive episode versus bereavement. All right, and maybe say, let me look that up. Didn't Dr. Jack cover that, or can I find that in a textbook or whatever? So, maybe that's a good time also to cover that area. So you're basically like navigating through, interrogating each new piece of datum that you're learning to see what it's made of and how it connects to other things locally, surrounding the other criteria, and then also more broadly, major depressive disorder. So the other thing to point out is, again, I'm keeping it as very simple, is when you read the DSM-5 or whichever version, 4, whatever, they've always been the same, very complicated, right? There's a lot of verbiage there. And that huge amount of verbiage really camouflages often very simple criteria, very simple concepts. For example, disruptive mood dysregulation disorder, all it really is 2 things. A lot of tantrums together with irritability between tantrums. Okay, I'm done, I'm moving on. Maybe now I can read about how to assess it and how to treat it, because that's really probably where I'm going to be tested on, right? ADHD, this is one of my favorite examples. You read all these criteria, there's so many of them, but they're really not symptoms. They're really just 3 basic symptoms of ADHD that are possible: impulsivity, distractibility, hyperactivity. All of the things in the DSM, they're just examples, like operationalized examples of symptoms, all right? You pretty much can guess what they are if you just know what the 3 symptoms are. How about somatic symptom disorder? There's really 2 things to know. I need at least 1 somatic symptom, all right? And as you probably heard me say before, I will replace the word somatic with physical, because I can remember that. It makes more sense to me. Like, oh, physical symptom, like pain or a headache or nausea or vomiting or I don't know, tingling, whatever it is. Okay, I get it. And then all I need in addition to that is some excessive behaviors related to my somatic symptom or to health concerns. So I'm either doing a lot of healthcare seeking, I'm seeking out doctors, I have a lot of worry, ruminations, and I'm feeling a lot of anxiety, and somehow related to my somatic symptom or just to my health in general. And then the last example, reactive attachment disorder. Well, there's 2 kind of global, boundary things I need to know. It's due to the prerequisite is that there had to be some extremely insufficient care during this person's childhood, right? Neglect, abuse, change of caregivers, institutional care. It's extremely insufficient care, right? And it has to present before the age of 5, okay? And then the symptoms are 2, emotionally withdrawn behavior And then social emotional disturbance. The kid is irritable, they're sad, they have no positive affect, they don't smile, they don't laugh at jokes, they're not happy to see you, and they often have a lot of fearfulness about them. Now let's look at something else that may be a little bit, again, maybe a little bit off to the side. Obviously, it's still part of the psychiatry board exam, but it's not a disorder that most psychiatrists even deal with. So that's why now I wanted to move to something that may be less familiar, right? So before I get into frontotemporal neurocognitive disorder, let's say I want to start off with the general criteria to understand what neurocognitive disorders are in general, right? And so I start reading the criteria: significant decline in one or more cognitive domains, right? And then I read what they are. It gives me a list in the DSM. And then it's based on report of patient, informant, or clinician. Oh, so I pause there, I kind of take that in. Oh, so it doesn't even have to be reported by the patient. It could be the patient's spouse. Oh, but it doesn't have to be the patient's spouse. It could just be me. It could be based on what I think, right? The patient, their spouse didn't notice, but I notice, and that's good enough to meet that criteria. And then I need to assess for substantial decline, right? So I'm noticing, oh, it's a substantial, let me kind of note that. And best if confirmed by neuropsychological testing or other assessment. Oh, it's best. It's not required, it's just recommended, right? It does interfere with independence of daily activities, not exclusively during delirium. Okay, got it, sure. Now I better explain by something else. MDD or schizophrenia. Remember, schizophrenia used to be called dementia praecox, like early cognitive decline. That's what Kreplin called it. So people with schizophrenia certainly do have cognitive and intellectual processing deficits. And MDD, right? Remember that thing called pseudodementia? That's just a part and parcel, oftentimes, of a major depressive episode, and then the person recovers, right? So that's why the DSM includes those two things in particular, right? So I'm thinking all this through. All right, then I go to mild neurocognitive disorder, and I get all of these words, 85 or 95%, whatever it is, are the same as for the major neurocognitive disorder. So it's like, okay, what is the difference here? Well, then maybe I say, well, let me make a table. What is the real differences out of all of that verbiage? This is it. First of all, I'm a little shocked when I put this on like 2 rows, or 2 columns, I should say, of a table, that it's major NCD and then mild NCD. They're not even opposites. It's not major and minor. It's not severe versus mild. It's major and mild. Okay, whatever. That's odd, but whatever. So major, I need significant decline in one or more domains. Mild, I just need modest cognitive decline. And of course, if it's more than modest, it becomes significant, and then I'm in the major NCD category. Next is cognitive deficits interfere with independence of daily living, versus in mild, they do not interfere with independence of daily living. Next is requires assistance with complex and instrumental activities of daily living. That's really like, going shopping, making dinner, balancing your checkbook, things like that. When in mild, it's complex AIDLs are preserved but may require greater effort, compensatory strategies, or accommodation. So maybe I used to balance my checkbook by doing longhand arithmetic. Now I use a calculator. Now I'm, putting in my appointments in my calendar, or whatever, right? I'm still okay, and I'm still sticking in mild because I'm able to compensate. And then major, it has a severity. It has severity specifiers. So mild, moderate, severe. Mild does not have severity specifiers. Then lo and behold, I stop and say, well, this is interesting. There's mild NCD, and then there's major NCD that could be mild, right? Okay, wow. Okay, let me maybe pause here and kind of take this in. How does major NCD with a mild specifier differ from mild NCD, right? And so I'm maybe thinking that, I'm paging it through, and I'll leave it to you to kind of look into that, right? All right, so now finally, like, wow, I thought I was going to start with frontotemporal, and I've had quite an adventure just reading the general criteria. So now I move on to finding frontotemporal NCD. That's sort of my focus for this evening, whatever. And okay, I read, criteria are met for major NCD, has an insidious onset and gradual progression. Okay, that's like Alzheimer's disease. That's probably like, Lewy body disease and other things, right? But particularly, I'd say Alzheimer's disease and Lewy body disease. That's the first thing, right, that pops into my mind at least. So I'm like, okay, I'll take that in. Then it presents in one of two variants, a behavioral variant and a language variant. All right, and I'm not going to go over those right now, but okay, I took that in behavioral variant and language variant. And of course, especially when I'm reading the behavioral variant, I'm probably going to try to imagine a person who presents with these symptoms, right? They're kind of socially, maybe they're obnoxious, they're inappropriate. What does it mean that they have perseverative or stereotype compulsive or ritualistic behavior? Well, maybe now I'm thinking maybe like, oh, okay, well, I've never treated folks for frontotemporal, but I've treated kids with autism spectrum, and so I can understand that if they get upset, like if they're not home at a certain time and they miss their favorite TV show, they get really agitated. Maybe it means that these people eat the same thing over and over, 3 times a day, whatever, right? I'm starting to, in my mind's eye, visualize what this person is. Oh, hyperorality. Oh, that's interesting, right? And dietary changes. Okay, good. And then language variant. Okay, that one is probably harder for me to imagine in my mind's eye, but whatever, I think I got that, all right? I understand aphasia, so it's whatever kind of aphasia. It's probably good enough for exam purposes, right? All right, what else? Relative sparing of other cognitive functions, right? Learning and memory, perceptual motor function is going to be relatively intact, okay? Now better explained by cerebrovascular disease, another neurodegenerative disease, a substance, another mental or medical disorder. All right, probably frontotemporal NCD, other than possible. If there's more information, I'm not going to focus on that right now. So now, if you actually crack open the DSM-5 after the frontotemporal NCD criteria, there's like a long, like 3 paragraphs or so of coding notes. And all of a sudden, it's talking about frontotemporal lobar degeneration. It's like, hold on a second, where did this come? Where did this come from? You haven't introduced this term. Where is this coming from? I'm not kidding. Look in the DSM-5. So all of a sudden, they're switching. I don't know if it was an oversight or what. So frontotemporal NCD, right, versus frontotemporal lobar degeneration. So let's say I'm confused by this, I want to look it up. Okay, frontotemporal NCD, frontotemporal. So it's really like the presentation that I would imagine, the syndromes I would imagine if I had damage to my frontotemporal lobes, okay? And I have these behavioral and these language variants. The behavioral ones, right, it's that kind of disinhibition, right, executive dysfunction, so forth, got it. Language, why language? Oh, Broca's language area is in the frontal lobe, right? And, anterior to the primary motor cortex, right? It's like, oh, so I'm probably expecting at least some of these aphasia variants to be like a Broca's type of aphasia, right? An expressive aphasia. All right, next is frontotemporal lobar degeneration. Okay, well now it's talking about degeneration of the frontotemporal lobes. Okay, that's all it means. It's another descriptive term. So frontotemporal NCD is focusing more on the clinical syndrome, the clinical presentation, while frontotemporal lobar degeneration, I'm assuming, focuses more on the disease process that attacks those frontotemporal lobes. And if I thought that, I'd be right, kind of going in the right direction, because in fact that is what those terms are referring to. So now there are various etiologies of these frontal lobar degenerations. If you're old enough to know the DSM-4, the DSM-4 did not have anything about frontotemporal dementia or frontotemporal lobar degeneration. It had Pick's disease. at the time, I mean, the DSM-4 was around for like 20 years. When it was first written, Pick's disease was the only identifiable etiology of a frontotemporal, dementia or degeneration. But now we know there are many, many causes, and every year we learn more and more causes. So what are the etiologies of the frontotemporal lobar degenerations where there is Pick's disease? I was actually really surprised to learn a couple of years ago, whatever, 2-3 years ago, that amyotrophic lateral sclerosis, right, the upper and lower motor neuron disease, is actually substantially associated with cognitive decline, right? About 20% of these individuals develop a frontotemporal type of neurocognitive disorder. Then there are 5 different mutations. There's more than 5 mutations. We know of several mutations that attack 5 genes. There are actually more than 5 mutations, and I'm not going to go into that right now. And then, amazingly, there's dementia, frontotemporal dementia, that lacks any distinctive histology, which just goes to show you that we're not very far along the path of understanding all the etiologies of these frontotemporal presentations. Oh, I forgot I had this in here, but this is actually a gross brain specimen of Dr. Broca's patient, and this person had the damage to Broca's area in his left frontal lobe, right? And that's it. So again, the whole point is to turn a passive learning, which is just, memorizing isolated facts and then turning it into information so it becomes more meaningful. And then it becomes most meaningful if I can incorporate that into my already very large existing knowledge base. And I can do all of this by continually, it's like I'm pinging, I'm interrogating each of these new pieces of information to see what they're made of and how they connect to other things. I hope this was helpful to you. If it was or it wasn't, please let me know. This is Dr. Jack signing off. You take care. Thank you.